I think the Sri Lanka Association of Oral Medicine and Pathology is a very, very sort of timely necessary association, because we have all other associations established. But I think there is a different role to be played by this particular society, and I'm happy that the Faculty of Dental Sciences, University of Peradeniya, is housing the Department of Oral Pathology as well as the Oral Medicine and Radiology, where very eminent academics are involved in both the faculty work as well as contributing much to this society as well. So, I think the active role played by them should be appreciated, especially on behalf of the postgraduates and also the other enthusiastic dental surgeons and other diploma sort of DHTP candidates, as well as the other general dental practitioners and everybody, because they cover a series of aspects where which is very, very necessary to practice an important group of diseases, common diseases, where sometimes the dental surgeons might be little sort of puzzled with in certain instances. Therefore, I thank Dr. Kalani Hettiarachchi and Professor Samadara Sirivardhana for joining today. I hope this lecture series would be very much interesting, and hope that more and more of this kind of activity, especially jointly, collaboratively, will take place in the future for the betterment of the profession. So wish you all the best, and thank you very much for joining hands with us. Thank you.
Thank you very much, sir. And today the topic is viral infections, and it will be done by Dr. Kalani Hettiarachchi and Professor Samadarani Sirivardhana. I don't think we need elaborative introduction to these two speakers today, because for all the undergraduate and postgraduate students and all other senior participants, they are well known. Professor Samadarani Sirivardhana, she is a professor in oral pathology attached to Department of Oral Pathology in Faculty of Dental Sciences, and Dr. Kalani Hettiarachchi, she is a senior lecturer in oral medicine and radiology and a consultant in OMF surgery, who is the head of the division of oral medicine and radiology. Without taking much time, I would cordially invite you, madam, to start the lecture and start the lecture. Over to you, madam. Excuse me, madam. We can't hear you.
Sorry. Thank you, Prasang. And at the outset, I would like to thank Sri Lanka Society of Oral Medicine and Oral Pathology for giving me this opportunity tonight. So today, as you all have heard, this is a series of lectures where we will be talking about different infections which affect the head and neck region. And to start with, we will be talking about viral infections today. There are different types of infections that affect different groups, that are caused by different groups of organisms. And these can cause infections in the head and neck area. And one such important organism is the viruses. And as we all know, any of the large group of submicroscopic infective agents that are usually regarded as non-living, extremely complex molecules. In the context of coronavirus, we all know this, and are typically contained or coated with a protein surrounding an RNA or DNA core of genetic material. And they are capable of growing and multiplication only in the living cells. And they cause various important diseases in humans, animals, and plants. So today we will be talking about the diseases that are caused in the humans, and especially in the head and neck region. And there will be many different viral infections and virally related diseases. And they can present with different manifestations. Some will cause inflammatory reactions, whereas some will cause systemic infections, whereas the others will cause certain neoplasias. Now, if I talk about the herpes virus group, it's comprised of a large family of double-stranded DNA viruses. And I'm sure that all of us know that there are 8 different subtypes in this herpes virus group. And the most commonly known or the best known members are the herpes simplex virus type 1 and type 2. We call them HSV type 1 and type 2. And HSV type 1 will predominantly cause oral lesions, whereas it will rarely cause the genital herpes. Whereas opposed to this, herpes simplex type 2 will mainly cause the genital herpes, whereas it will give rise to oral herpes in a minority. And the third type is the varicella zoster virus. This is known to cause chickenpox, as well as the reactivation of the lesions will cause shingles, or it is also known as the zoster, herpes zoster. Then the type 4 is the Epstein-Barr virus. Epstein-Barr virus is known to cause mainly in the head and neck area the infectious mononucleosis, oral hair leukoplakia, and the nasopharyngeal carcinomas. Apart from that, it can give rise to Burkitt lymphomas and the central nervous system lymphomas. Then the type 5 is a cytomegalovirus. This is known to cause infectious mononucleosis-like symptoms. And in addition, the cytomegalovirus is also responsible for diseases in the salivary glands, like cytomegalovirus inclusion disease. Then we have the 6, 7, and 8 viruses, which are much less is known about this. However, human herpes type 6, which is also known as the roseola virus or roseola-associated herpes virus, will give rise to the roseola infection. Whereas the type 7 still doesn't have any name. And again, both 6 and 7 will give rise to the roseola infection. And finally, the HHV type 1, which is also known as the Kaposi sarcoma associated herpes, is known to give rise to Kaposi sarcoma and associated with other types of lymphomas. If we just look what happens when a person is exposed to herpes virus, as the primary infection, when the person is exposed, the virus will start replicating within the body. And this is called as the incubation period. During the incubation period, the virus can spread and others can also get infected. And with the development of the virus, the patient will develop viremia, which will lead to the prodromal stage. During the prodromal stage, there will be systemic features. And usually these are non-specific. The patient will experience fever, malaise, body aches, and headaches. Then the virus will go to their affinity areas and give rise to features, especially when we are talking about the head and neck region, like oral ulcers. And at this stage, the body's immunity system will activate and it will go into resolution. However, this herpes group of infections are quite popular because it derives from a Greek word, which means that they creep or crawl, which means that there is a tendency for spread and latent or recurrent infection. That is the significance with this herpes group of infection. Therefore, what happens is, for the reactivation, there are memory cells or the B cells, which will keep the memory forever whenever the body's host defense mechanism gets activated. And therefore, when a patient is exposed, the infection will not settle. And these memory cells are being formed. But before these memory cells are formed, the virus can shed their outer capsule and then travel along the sensory nerves, where they can stay latent in these sensory root ganglions. They can stay latent for many, many years. And then if there is any condition where the host's immunity gets depressed or suppressed, then they will get reactivated and recurrent infection will be caused. So the most common viruses, the herpes simplex virus, type 1 and type 2, these will cause significant pathologies in the head and neck area. And the severity will mainly depend on the immune state of the person. And if the patient is immunosuppressed, they are having the risk of getting a disseminated disease. The primary infection that is being caused by the HSV type, HSV group of infections, viruses, is the acute herpetic gingival stomatitis. As the name suggests, it is self-explanatory. It says acute herpetic gingival stomatitis. Acute in nature because this will only last from several days to weeks. Whereas the virus that is causing is herpetic herpes simplex virus, so it is known as herpetic, and the gingival stomatitis because of the main involvement of the gingiva and the perioral tissues. And clinically, they will have high fever, irritability, and inability to eat. And this is having a special affinity in the younger population. And especially when a person is initiated or exposed at the initial stages without any antibodies, they will develop the disease. However, it will be not very significant morbidities will be there with this. And the disease will last only for about few weeks time, and patient will remain infectious for days and weeks after the symptoms even have disappeared. Here on this picture, I have shown few pictures of patients who are affected with acute herpetic gingival stomatitis. And clinically, these oral ulcers will look more or less like acne ulcers. And therefore, but the child will have multiple ulcers. The child will have multiple ulcers, and these ulcers will be quite painful. So they will be unable to eat or drink anything. You can see some vesicles sometimes develop on these tissues. Then in addition to that, I was talking about gingival involvement. You will see reddish erythematous gingiva. Now, when you see this picture, clinical picture, the main differentials that we can think of is mainly the leukemic conditions, acute leukemia, which is also more prevalent in this age group. But by doing a simple full blood count, you will be able to exclude the possibility of a leukemia because there will be other features like platelet deficiencies and anemia coexisting with the leukemic patient. Then the acute herpetic pharyngotonsillitis. When we talk about the HSV infection, the age of initial infection will decide the clinical presentation. Now, the earlier feature was mainly seen on the younger population, and in adults, this infection will give rise to pharyngitis and tonsillitis more than the gingival stomatitis. And clinically, they will again have fever, malaise, and headache-like features, and they will develop numerous small vesicles, especially in the tonsils and the posterior pharyngeal regions. And these vesicles will rupture and give rise to shallow ulcers. When you talk about the diagnosis of HSV, this diagnosis is made mainly by the clinical manifestations. So the history is quite typical, and it is not quite difficult to make a diagnosis out of the clinical presentation. But there are certain investigations that can be performed if you are suspecting primary herpetogingival stomatitis in a child. The first investigation that can be done is a simple full blood count, which will show either a normal or a low WBC-DC count and a lymphocytosis. However, this is not quite specific to HSV infection, and the only thing that we can tell is that there is a viral infection going on. Apart from that, we can do a smear or a brush biopsy if the child is having intact vesicles, or even we can take scrapings from the ulcers. When we talk about immunology, there can be elevated antibody levels, which are specific diagnostic investigations. But the problem with this is these specific antibodies will increase at a later stage of the disease, when the immune reaction is at a full-fledged. Therefore, when you have an elevated antibody level, the patient is no longer having the clinical features. Therefore, unless the child is immunocompromised and having a prolonged disease, the immunological investigations will not be of any value. Viral culture also can be done, which will have a positive result. Which will, even though it has a positive result, it will not mean that it is the virus that is causing the disease, because there can be transient viruses that is present in the mouth, which may give rise to a positive result. So therefore, the main diagnostic tool can be considered as the clinical manifestations or the clinical presentation, which is quite classic. However, these other investigations are also available. Then the treatment is mainly aimed at the symptomatic management, because these infections will not last for long, and also the complications are very, very minimal. Therefore, mainly the pain relief, improvement of the hydration. If the child is having a fever, prescribing antipyretics, and improvement of the oral hygiene can be considered. And especially acyclovir is reserved if the child is immunocompromised. Either it can be given as oral acyclovir or topical prescription. If it is oral acyclovir, we can go for a maximum dose of 200 milligrams for 5 times 5 days. Then the recurrent herpetic infection, or the herpes labialis, which is commonly known as herpes labialis. As I told you, an inherent feature of this herpes group that they can go into latent time periods and then get reactivation. So the reactivation of the simplex virus is the herpes labialis. The virus can go along the trigeminal nerve and can get latent in the trigeminal ganglion, and then later become reactivated, giving rise to the vesicles and the ulcerations. Especially on the involvement of the upper lip is common, and they will have the prodromal stage of pain, tingling, and burning sensation. This is also known as the cold sores or the fever blisters. On this second picture, I have shown some blistering on the upper lip. That is quite characteristic for the cold sores. Slides are changing automatically. I'm sorry about that. Right. Then, moving on to the varicella zoster virus. This virus is known to cause chickenpox and the shingles or the zoster infection. And the manifestations in the head and neck region usually occurs after the initial infection of the chickenpox. And following this, the virus will enter into the dorsal root ganglia of the spinal cord, and it can remain latent in this region and become reactivated whenever there is a immunosuppression. So, resulting in herpes zoster infection with the reactivation. However, the reactivation can happen in the ophthalmic branch, and this can give rise to very serious complications, which includes the herpes ophthalmicus. When this happens, a patient can develop conjunctivitis, corneal ulcerations, which may even lead to blindness. Therefore, if a patient presents to you with zoster infection involving the ophthalmic branch, it is always better to refer the patient to an ophthalmologist as early as possible. Then we will be discussing about the Ramsay-Hunt syndrome, then about a complication that occurs with the varicella zoster infection is the post-herpetic neuralgia. This is one of the important complications of varicella zoster infection. And this is when there is serious continuous pain that presents. So if the pain is persisting and lasting for more than 3 months on the day of the ulcers were first seen, then we usually consider it as post-herpetic neuralgia. Here I have included some photographs of patients with zoster infection, and on this, the first picture you can see the involvement of the mandibular branch, and there is the ulcers have healed and there is some scarring present. Whereas these other two photographs show the involvement of the maxillary branch, and you can even see the intact vesicles in these 2 cases. And not only the skin that can get involved, even the oral cavity can have ulcers and blisters. The characteristic features of these lesions are that they will not cross the midline. It's quite characteristic and diagnostic, especially when there are less number of blisters present on the skin, but many on the oral cavity. The lesions not crossing the midline, lesions doesn't crossing the midline will be quite significant. Then a word about Ramsay-Hunt syndrome. Usually the virus will travel in the sensory nerves of the trigeminal nerve. But in rare situations, it can travel along the sensory nerves of the facial nerve as well. And then the virus will remain dormant in the geniculate ganglion. And later, getting reactivated will cause a condition called Ramsay-Hunt syndrome. So this is quite characteristic because you will see the cutaneous lesions of the involvement of the extra-auditory meatus. You can see that there are scarring and ulcers present on the external auditory meatus as well. And there is its lateral facial nerve involvement. Its lateral involvement. And you can see the mandibular branch here with the scarring. And also in Ramsay-Hunt syndrome, the significant thing is with the involvement of the facial nerve, you will see the facial palsy. Here you can see the partial closure of the right side because of the facial nerve palsy that is there. Together with the facial paralysis, these patients can have hearing defects, vertigos, or other involvement of the auditory and vestibular symptoms. And also because of the involvement of the facial nerve, there can be loss of taste from the anterior 2/3 of the tongue. And about the hand, foot, and mouth disease. This disease is mainly caused by the group A Coxsackie virus and also in group B, and this is commonly seen in the children. And this is a seasonal disease, especially seen during the dry seasons. Even in Sri Lanka, we see it from time to time whenever there is a dry season. So as same as primary herpetical gingival stomatitis, there will be an incubation period followed by a prodromal stage where the child will experience fever, sore throat, loss of appetite, body aches, and these common symptoms. And followed by painful oral ulcers, which are not only restricted to the oral cavity, but there will be involvement of the hands and the legs as well. The healing will usually happen within few days, and the treatment is directed at symptomatic management. You can here see the picture of a patient with the involvement of the hand, and even in the mouth you can see the oral ulcers. Then herpangina, this is not very common. Again, it is caused by the group A and also group B Coxsackie virus, and the lesions are quite similar to the hand, foot, and mouth disease. But here the main involvement is in the posterior part of the mouth, which can extend into the throat. Again, the management is directed at a symptomatic management. And about infectious mononucleosis. So this is caused by the Epstein-Barr virus, the type 4. And it causes many diseases. Out of that, infectious mononucleosis is one of the important ones, and it is known as the glandular fever as well. And as these can spread through the saliva of someone, and especially if a person is carrying the infection and if they kiss somebody, the disease can get transmitted. Therefore, it is also known as the kissing disease. And the clinical presentation usually varies with the age. And children, when they are affected, they are more or less asymptomatic. But if the child develops symptoms, they can have fever, lymphadenopathy, and pharyngitis-like symptoms. And in the adolescents and young adults, the infection will usually result in the development of infectious mononucleosis. And usually these Epstein-Barr virus will infect the cells, resulting in B cell activation and proliferating in the host. Usually the characteristic features of infectious mononucleosis would be high fever, sore throat, and lymphadenopathy. And there will be marked tonsillar enlargement. Even on this picture, you can see the enlargement of the tonsils. Sometimes This can go into the extreme cases where the obliteration of the respiratory tract happens and intubation may be required in certain cases, in such patients. And also in some cases, you might see the development of petechiae on the hard and the soft palate in about 25% of the cases. But usually they will disappear within 24 to 48 hours. And the diagnosis of the infectious mononucleosis is commonly based on the clinical presentation. And combined with the presence of a greater than 10% of the atypical lymphocytes on the peripheral blood smear will be diagnostic. And at the same time, the laboratory findings are aimed to find whether there are heterophil antibodies present. Therefore, the Paul-Bunner test or the monotest can be performed in order to see whether there are these heterophil antibodies present. Even though there is lymph node enlargement, the lymph node biopsy is not usually necessary and it is very rarely indicated, especially when there are confusing features seen on the blood picture, because these changes or the appearances in the lymphocytes sometimes can be confused with the lymphomas. Therefore, very careful interpretation is necessary and to prevent the wrong diagnosis. In most cases of infectious mononucleosis, these will resolve within 4 to 6 weeks. Therefore, it is self-limiting. However, treatment is mainly supportive and NSAIDs can be used to minimize the common symptoms. At the same time, adequate fluid intake and nutrition are also important aspects in the management. And the infection may be disseminated and fatal, especially in the immunocompromised patients, and it can result in secondary infections as well. And usually, the antiviral therapy is not very effective simply because the main clinical manifestations of the infectious mononucleosis happen with the, as a secondary response, immune response that they show with the B-cell lymphocytosis. And this is not being altered with the antiviral therapy. Then another infection that is being caused by the Epstein-Barr virus is the oral hairy leukoplegia. And these lesions are quite important because they are more commonly present in the HIV-infected patients. And also it is reported in immunocompromised status, such as in transplant recipients. And therefore, if you see oral hairy leukoplegia in a patient, it is always crucial to assess the immunity of that patient and to suspect any immunosuppression that may be underlying. And it is very rarely, because it is very rarely seen in the immunocompetent patients. And the commonest sites that are being involved are the lateral border of the tongue. But there can be other sites like the dorsal and ventral surface of the tongue, buccal mucosa and gingival involvement. But the commonest and the characteristic typical presentation would be on the lateral. Usually, these are the presentations that you see on the lateral border of the tongue, and usually they will not get rubbed off. And they will present as white plaques that are present on the bilateral tongue. Then moving on to the human papillomavirus infection, this disease contains a large group of double-stranded DNA viruses, which are from the family of Papillomaviridae group. And it can cause many different problems, which are not only in the head and neck area, but in other regions as well. And although the herpes human papillomavirus is associated with benign conditions, it can also sometimes be associated with the neoplasias as well. For an example, cervical cancers and the oropharyngeal carcinomas. And the most infected individuals are asymptomatic and they will lack the clinically evident disease. And these are the lesions that are commonly associated with the human papillomavirus: the squamous cell papilloma, verruca vulgaris, condyloma acuminatum, Higgs disease, and the oropharyngeal carcinoma. Then about squamous cell papilloma, these are mainly caused by the HPV type 6 and 11. And the sites that we will be seen, these commonly would be the palate, tongue, and lips. But also the oral surfaces can also get affected. And these lesions present as soft tissue masses arising from the soft palate. And they will appear as very soft, painless, usually pedunculated, exophytic type of nodules with numerous finger-like projections that give rise to a cauliflower-like or a wart-like appearance. And these projections can be like blunted or very prominent in nature, and depending on the amount of surface keratinization, they can either have whitish or slightly reddish feature. And here you can see the exophytic lesion on the soft palate, even though that is not a very quite common site to have this. You can see some multiple short white surface projections. And on this lower picture, you can see the pedunculated mass in the buccal commissure exhibiting short blunted surfaces. And it is sometimes difficult to distinguish these lesions clinically from the verruca vulgaris and the condyloma acuminatum. And the management, of course, would be conservative surgical excision, including the base of the lesion. And oral squamous cell papillomas are quite, the recurrence is unlikely. Then verruca vulgaris or the common wart, these are focal benign human papillomavirus induced hyperplasias of the stratified squamous epithelium. And usually this is caused by the HPV type 2, and even type 4 and 40 can give rise to verruca vulgaris type of lesions. And usually they are found on the vermilion border of the labial mucosa on the anterior tongue. And typically the verruca will appear as painless papules or nodules with papillary projections. And these are contagious and can spread to other parts of the person's skin or the mucosa by autoinoculation. And these lesions can again be usually excised surgically, or either laser can be done, cryotherapy and electrosurgery are the other treatment options. Then condyloma acuminatum is again another HPV-induced proliferation of the stratified squamous epithelium, with especially in the anogenital region, but you might see lesions in the mouth and larynx as well. And 90% of these are caused by the HPV 6 and 11, and usually this is a sexually transmitted disease. And it may be an indicator of a sexual abuse when diagnosed, especially in young children. So you have to be suspicious if you see such lesions in small children. And they will appear as sessile, pink, well-demarcated, non-tender, exophytic mass. Then a word about Hex disease, which is also known as the multifocal epithelial hyperplasia. So originally, this was termed as focal epithelial hyperplasia. But now we use the term multifocal epithelial hyperplasia, which is being preferred because these patients usually exhibit multiple lesions. And the known strains are the HPV 13 and 32 to cause the Hex disease. And predominantly these will arise in children and in adolescents. And the most common site of involvement would be the labial, buccal, and lingual mucosa. But there can be other sites like gingiva, palate, or the oral floor can get affected. And there are two clinical variants in the Hex disease. One is the papulonodular. The top picture shows the papulonodular lesions, and this lower one is the papillomatous type of lesions. The papulonodular variant is the most common type, where it is characterized by pink, smooth surface papules and nodules, with predilection for buccal mucosa and the labial mucosa. So these lesions are present on the labial mucosa. On the other hand, the papillomatous lesions will be like white pale pink, and which will have a pebble-like nodules on the tongue and the attached gingiva. So again, spontaneous regression has been reported. This is not a very common disease, So therefore, with the limited reports that are available, they have shown that there is a spontaneous regression after several months and years. However, surgical excision can be considered for diagnostic and aesthetic purposes, and also if these lesions are subjected to recurrent trauma. These lesions can be taken out either using the scalpel or with the cryotherapy and carbon dioxide lasers. Then finally, about Kaposi sarcoma, which is caused by the HHV type 8 or the Kaposi sarcoma associated virus. And before the advent of the AIDS or the acquired immunodeficiency syndrome epidemic, this was a rare tumor. But with the diagnosis of AIDS, now it has become a very common lesion or condition. And again, with the invent of the antiviral therapy, antiretroviral therapy for the AIDS, this has become less, or it has rather declined. And this is an unusual vascular neoplasm. And there are different clinical presentations which are termed as classic, endemic, iatrogenic, and epidemic, especially in the AIDS-related patients. So if you see such lesions, especially on the palatal region, then you have to suspect about any immunosuppression in such cases. And the treatment depends on the clinical subtypes and the stage of the disease. And the prognosis is variable depending on the form of the disease and the patient's immune status. Right. Thank you.
Thank you very much, madam, for your very informative and illustrative lecture. And I would like to invite Professor Samandarani Sirivardhana. Madam, over to you.
Thank you very much. And it's thank you for giving the opportunity to discuss about the pathological aspects of the viral infections. Dr. Kalani has discussed about the clinical aspects and also the management. So I'd like to express the views from the pathology side, because how this clinical presentation happens. Here, the herpes, human herpes virus group have up to 8 types. Commonly, HHV or HSV1 and HSV2, as Dr. Kalani said, they are oral herpes as well as genital herpes. So when we check about the pathogenesis, the viral particles coming into the oral epithelium, where there is trauma or some damage to the epithelium, then they enter into the epithelial cells, and they have the affinity towards the sensory nerves, and then it stays in the ganglia, and then there's reactivation. So why these vesicles are coming or erupting? The reason is the virus are multiplication within the cells, and then there are lysis of cells. And because of this lysis, there are formation of vesicles. So that's why clinically it presents as vesicles, and then ultimately it becomes as ulcers. So the oral HSV1 preferred to stays in trigeminal ganglion, and also the HSV2, which causes genital herpes in the lumbar or sacral ganglia. Then when there's reactivation, so preferably the oral herpes comes to the trigeminal, along the trigeminal nerve, and gives vesicles and ulcerations. Normally, it is a clinical diagnosis, But there are instances, the performing biopsies. Once we have the biopsy, we can see this vesicle formation. So there's a vesicle. So normally the epithelium is covered by the stratified squamous cells or the keratinocytes. And because of this degeneration and destruction, there's a vesicle formation within the epithelium. So that's why clinically it looks like a vesicle. And these are the cells, degenerating cells. They are called SANG cells or the floating cells. And also the epithelium is edematous. So that's why it is a swollen area, the clinically. And normally we get, so we can perform a smear from the vesicle, and there we can see these multinucleate cells. So they are squamous cells. They get together and form a multinucleate large cell. And clinically, when they take the smear, we can see this kind of ballooning cells and also giant epithelial cells. And this is not non-specific because viral infections gives the same appearance, but we need to have other tests to check the type of virus. And here we can see the ballooning of cells. So they are enlarged cells, and also the chromatin. So that's, you can remember, hope the nucleus have a purple color dot. And this chromatin is dispersed, and then they are along the nuclear membrane at the periphery. Characteristic features of these viral infections. And also there are some inclusions, viral inclusions like here. And also these multinucleate cells are seen in a biopsy specimen. And then the chickenpox. So first the route of infection is the mucosa or the upper respiratory tract, and or through conjunctiva. And then first it's in the viral replication in the lymph nodes. And then first there's viremia. And the mostly diagnosis is clinically. And again, the smear shows these the multinucleate cells as also the floating SANG cells. Definitive diagnosis can be done with the culture, and also virus-specific antibodies can be detected using a fluorescent antibody and also ELISA or enzyme-linked immunosorbent assay. And again, the zoster will comes with the latency, and then with reactivation, again gives the vesicle formation. Then the Epstein-Barr virus. As Dr. Kalani clearly described the clinical presentation, so this the virus comes and enters into the epithelial cells and also to the B cells. So that's why the tonsillar area get enlarged. So these B cells start the T cells and B cells, they are disseminated to the other lymphoid tissue. And then there's formation of antibodies in the system. But about 90% of them, it's self-cured. But about 10% of cases can have the other transformations. For example, so the Epstein-Barr virus can give rise many diseases. So here, these patients have the fever, pharyngitis, lymphadenopathy, splenomegaly, because pharyngitis because of the infection of the epithelial cells, and then there's a destruction. So then the inflammation is there. So that's why they get pharyngitis. And lymphadenopathy because of the accumulation of B cells, infected cells in the lymph node, and then they start proliferating within the lymph node, and then there's enlargement is taking place of the lymph node. So then they get lymphadenopathy. And again, splenomegaly, because B cells and T cells, cytotoxic T cells, so that is CD8 cells, they are accumulating in the liver. So then they get splenomegaly. And this is not only for EBV. So if there is cytomegalovirus, HIV, toxo, and hepatitis, again, they have these features. So when there's reactivation in immunocompromised host, so there may be lymphoproliferative disease, and there may be mutations which can lead to lymphoma. In lymphomas, you can see mononuclear cells. So that is the same type of cells proliferating. So that is mononucleosis. So these are the different diseases caused by Epstein-Barr virus, and I would like to just explain about nasopharyngeal carcinoma, a little bit of Burkitt's lymphoma, and this is a lymphoma caused by Epstein-Barr virus. So this is a T cell lymphoma. Burkitt's lymphoma is a B cell lymphoma. So this is a T cell lymphoma because CD8 cells are affecting. So here we have to diagnose. It is necessary to demonstrate the virus. So these many cells are the Epstein-Barr virus positive. So this is in situ hybridization. So these bluish deposits are the viral infected cells. And also with the double staining, so this is CD8 cells. So that is the lymphocytes. And also within these lymphocytes, they have to have EB virus. So then there's a method called double staining. So with that, we can see a pinkish presentation, the pinkish expression. So that means the virus is there. The infected cells are positive in here also. So this is another lymphoma caused by the human herpes virus type 4 or EBV. And this is Burkitt's lymphoma, which is very aggressive and mostly seen in children, but if it is the stage 1 and 2, it's curable, but 3 and 4, it is curable, but you have to treat properly. And early stage, the diagnosing at early stage is very crucial for the management. So this is lymphoma. So you can see the same size of cells are dispersing throughout. So this is actually, it's called starry sky because it's like a stars in the sky. These stars are actually macrophages. They are called tingible body macrophages because these are vacuolated cells, and the other cells are the sheets of mononuclear cells. And the Epstein-Barr virus, the other one caused the nasopharynx is the malignancy. The nasopharyngeal carcinoma is again a very aggressive tumor and spreads very fast because you can see these are tumor islands. And here also the necrosis is there because it's fastly growing. And if we stain with the tumor cells with the Epstein-Barr virus antibody immunohistochemically, so all these cells are positive for the EBV. And then the hairy leukoplakia, again, the other disease that caused by Epstein-Barr virus, especially immunocompromised patients or HIV patients, because sometimes these are transient, because in immunocompromised patients who are with immunosuppressive therapy, or like organ transplant patients, they also can develop this kind of lesions, but it should be keep in the mind, so to check their immunity, as Dr. Kalani said. So why this appearance? Because of these epithelial cells are infected by EB virus, and then there are apoptosis as well as necrotic cells. So that's why these degenerating areas, we can see the cells are swollen and absorbs water because oral cavity is always wet. So that's why this white color appearance. And the biopsy, if we take, here we can see this whitish area is swelling. So that's why clinically it is whitish color. And also thickness of the epithelium also increases, so which masks the underlying blood vessels. Again, it becomes pale color. And characteristically, so this kind of ring or the beading appearance is there in characteristic, as a characteristic feature for hairy leukoplakia. And for confirmation, we have to do in situ hybridization for EB virus. And this is in situ hybridization for EB virus DNA. So these dark areas are virus present in the tissue. So in situ hybridization means we need to take this sample or the tissue, and then so we need to add the antibody to the tissue, and then it's like PCR doing in the tissue. So then it start proliferating, and then we can see the replicated is viral DNA. So that's why it is visible after in situ hybridization. And the Kaposi sarcoma, again, the herpes virus or HHV8, it's a tumor arising from the vascular or lymphatic endothelial cells. But with the relationship with the virus, it's not well understood. But the presence of this kind of lesions are the differential for melanoma, as well as if there are, because there are three clinical types. Patch stage, it is just a small patch, blackish patch, and then it elevated a little bit. It's plaque type, and then once it comes to the late stage, it becomes a nodular stage. So the patch stage is more crucial because it's difficult to diagnose histopathologically as well as clinically, because it looks like amalgam tattoo or maybe early stage of melanoma. So it's better to keep it in the mind. So this could be a differential diagnosis, a Kaposi sarcoma. So histopathologically, it's a vascular tumor, and there are spindle cell proliferation, and also the viral is positive. We can detect virus in these cells. Then the human papilloma virus. So in human papilloma virus, commonly we can see the verruca vulgaris or viral wart, venereal warts, as well as squamous cell papillomas. But herpes, human papilloma virus types are different for different, for viral wart, it's 2 and 4, and squamous cell papilloma and 7 and 11. And also the venereal wart, again, 2, 4, and 6. Clinically, the whitish exophytic lesions because of these keratin, and keratin absorbs water. So that's why clinically it's become whitish color, but under the microscope, it is pink color because these stains with the eosine. So it is pinkish color, the keratinized area. And these projections can see clinically as a verruciform growth. And in these lesions, because it is viral origin, there's virally damaged cells. So these vacuole cells or the clear cells with a shrink dark nucleus or squeezed nuclei. So those are virally damaged cells. So they are called koilocytes, can be seen in the surface layers of the biopsy or the specimen. And the squamous cell papilloma, again, the same projections are there. The connective tissue core is going in between, and the multifocal epithelial hyperplasia or HEX disease. And clinically, there are two types. And histologically, what we can see is hyperplastic epithelium because it's growth. And then within that, there are mitozoid bodies, which are due to viral damage. And the other one is the squamous cell carcinomas, where due to the human papillomavirus, especially in P16, in dysplasias as well as oral squamous cell carcinomas, where the patients who do not practice any risk habits, so this may be the possible candidate, the HPV, which can give rise these cancers. Especially the human papillomavirus type 16 and 18, they are called high risk HPV groups. They have E6 and E7 proteins, and E6 binds with P53 and it alters the function, and E7 binds with retinoblastoma gene, which release the E2F, and then ultimately there's increased P16 expression, which is a surrogate marker for the diagnosis of P16 induced squamous cell carcinoma or dysplasia. Dysplasia and HPV is very important because squamous cell carcinomas with HPV originated are very, when we do the treatment, it is there's a unique clinical management because it's very sensitive and very responsive for chemoradiation. So histopathologically, dysplastic lesions are very different from the normal routine dysplastic like the other mild, moderate, severe. So this HPV-induced dysplasia have the very typical form of cellular atypia, and very prominent and bizarre cells are there. And here you can see this epithelial dysplasia, those who have seen the dysplasia mild, moderate, severe, if those who can remember, this is different. So we can see a kind of very altered dysplasia with a lot of atypia. And we need to stain with immunohistochemically P16, but P16 expression itself does not say this is due to the virus, because P16 expression can be due to virus or maybe due to some other reason. So we have to stain with HPV as well. So first we have to stain with HPV and then stain with P16. If both express, then it is due to P16. And again, in situ hybridization is necessary for confirmation. So this is HPV DNA. So you can see all areas are positive. In normal epithelium also we can detect HPV DNA, but not P16. And high risk HPV groups also we can detect. Here, so this should be P16, P16 and 18. Sorry about this. So here you can see the expression. So blue dots means in situ hybridization. So after staining, it becomes bluish color. So this is positive. So this is P16 and 18. And P6 and 11 are the low risk ones. So it doesn't show any expression. So that's all for the pathological aspects of viral infections. And thank you very much.
Thank you very much, madam, for your very informative lecture. And we have few questions. The first question is, please give an account on oral manifestations of COVID and their management. I think this question is for Kalani madam.
Right. Thank you for that question. In fact, like there are various oral manifestations that have been reported, but in fact, we did a study in Sri Lankan population where we examined 100 patients, and we found out that the most common oral complaints were the anosmia and the agousia, which is the loss of taste and the loss of smell in 72% of the cases. Apart from that, the third most common one was the burning sense, the dry mouth. Dry mouth was the third one, and the fourth one was the pharyngeal soreness. So seeing this dry mouth was a bit significant in our population because 69%, 72 had this loss of taste and smell, whereas 69 reported about perceived dryness in their mouth. And we followed these patients for a 1 week time period. And to talk about the examination findings, we didn't see much changes. There were only 3 cases which presented with ulcers, oral ulcers. They were like aphthous type of ulcers, which were present on the buccal mucosa. And apart from that, 2 patients whom on the initial presentation had a coated tongue, whereas after 1 week, another patient developed the coated tongue. And within 1 week, these have resolved in patients who were there with the initial presentation. So I think even though there are various reports in other contexts, in Sri Lankan context, I would like to say that we don't experience much oral lesions such apart from aphthous type of ulcers, which is also again the common type of lesions that is described in the literature also. Apart from ulcers, they have talked about candidiasis, angular cheilitis, and herpetic-like lesions. So I think we saw some oral ulcers and the coated tongue. And the complaints were the loss of taste, loss of smell, and the dry mouth. We did not, unfortunately, we couldn't assess whether there is actual dryness present or not, but we took it as because the patients perceived it as dry mouth with the onset of the disease. I hope I answered that question.
Can I add something, Kalani?
So sure, sir.
Now, most of the oral complaints that we get, they are not directly related to the COVID infection. Now, for example, when you look at the dry mouth, it is mostly due to the associated factors like stress and all that than a COVID-related direct symptom.
Yes. Sir.
Even the aphthous ulceration, it is the case. So far, other than the loss of taste and smell, none of the others we have evidence to say that these are due to the COVID.
Yes, true.
The loss of taste and smell it is, but whereas the others, they are most likely associated factors than a direct effect of the virus. Thank you.
Thank you, madam, and thank you very much, sir. And the next question is from Dr. Jinadasa. He's asking, please explain viral infections of salivary glands. Samdara madam, could you please answer that question?
Viral infections, especially mumps, we can see, but and again, the cytomegaloviral inclusions also we can see. Other than that, there's not much, I think.
Thank you. Another question from Dr. Chinadasa. How to differentiate vericopapillary hyperplasia from hairy leukoplakia histopathologically? I think this question also,
Yes.
Madam has to answer.
Yeah, so vericopapillary hyplasia, we can see exophytic lesions, both exophytic, but hereleucoplakia, it's not that exophytic. Clinically also it's different, but histopathologically, the vericopapillary hyplasia, sometimes we can see very pointy, sharp projections with a lot of keratinization. But hereleucoplakia, we don't see that keratinization as well as in hereleucoplakia, there's spongiosis and also edema of the epithelium. And also the beading, sometimes we can see this beading nuclear appearance, but mainly these are swollen and very edematous. But vericopapillary hyplasia, we don't see that edematous epithelium in the context of histopathological.
Thank you very much, Madam. I think those are the all questions that we got from our participants. And I would like to thank Dr. Kalani Hettiarachchi and Professor Samandara and Sirivardhana for the excellent presentations and valuable clinical and histopathological explanations given to all of us. And also, I would like to invite all of you to join the next webinar on fungal infections on 21st December. Also, on behalf of the Sri Lanka Society for Oral Medicine and Pathology Council, I would like to invite you to become a member of SLSOMP and have the privilege of joining academic and professional development programs which are exclusively for SLSOMP members. I hope this was a fruitful hour for all of us. And thank you again for joining, and good night.